All right, let's unpack this. Today, we're taking a deep dive into a pervasive yet often misunderstood equine disease, strangles. You might have heard the name, but this goes way beyond just a simple infection. It's a condition with a surprisingly deep history and, well, a persistent global impact.
Yeah, and what's truly remarkable, I think, is how centuries of human-horse interaction have profoundly shaped its very existence and spread. Our big takeaway today, Strangles isn't just, a horse disease. It's almost like a mirror reflecting centuries of human activity. We'll unpack how our past and present actions are really the key reason this ancient scourge still plagues horses worldwide, and maybe what we can learn from that to, well, finally get ahead of it.
Okay, so to start us off then, when we talk about strangles, what exactly are we seeing in a horse? Like, what does this disease actually look like?
Right. So at its core, Strangles is an acute upper respiratory tract infection in horses. The classic signs are a high fever, often above 103 Fahrenheit or 39.5 Celsius. You'll see noticeable depression in the horse's demeanor, kind of lethargic.
Yeah, just looking really off.
Exactly. And that thick, pus-filled nasal discharge, that's what we call purulent rhinitis. Plus the really distinctive bit, the development of painful, swollen abscesses in the lymph nodes, especially under the jaw and in the throat area, the retropharyngeal ones.
Okay.
You might also notice difficulty swallowing, maybe an abnormal respiratory noise, that stridor, or the horse extending its neck, trying to get comfortable.
And this isn't just like a local barnyard problem, is it? We're talking bigger scale.
Oh, far from it. This is the most frequently diagnosed bacterial infection in horses globally.
Right.
Seriously. To give you a sense of scale, in the UK alone, they report over 600 outbreaks every year.
Wow.
And get this, between 2008 and 2018, it was the third most diagnosed pathogen in biosurveillance. It had like a 7% infection rate in those studies. It's truly a worldwide challenge.
It's pretty wild to think that this disease was first described by someone named Rufus way back in 1251. Yet, despite centuries of, seeing it, it took until 1888 for the specific bacterial culprit, Streptococcus equi, to be nailed down by Schutz. That seems like a huge gap.
It absolutely is. And what's particularly striking is that despite all that awareness, centuries of it, and decades of actual scientific understanding, Strangles stubbornly persists. I mean, genetic analysis shows modern S. equi strains. They share a common ancestor from the 19th or maybe early 20th century.
Yeah.
Think about that period. It correlates directly with massive horse mobilization for things like World War I.
Right, and the big national studs forming?
Exactly. These human activities, totally inadvertently, created perfect conditions for a highly fit strain to emerge and just spread globally. It really underscores how human actions, both way back then and even today, like, say, not enough pre-import screening of horses, continue to be a major driver of its prevalence.
That historical context is truly fascinating, isn't it? It makes you wonder, what kind of microbe is this? How could it endure for centuries and even thrive, partly because of what we were doing? Let's dive into the biology of the strangles bug itself.
Okay, so the bacterium responsible is Streptococcus equi subspecies equi. We usually just shorten to Strep equi. It's a highly specialized type of bacteria, gram-positive, capsulated, beta-hemolytic, all the technical stuff. But crucially, it's what we call an obligate parasite and a primary pathogen exclusively in equids.
Meaning just horses, donkeys, mules.
That's right. This isn't a bug that jumps species easily, if at all. Its genome has essentially been streamlined over time. It's lost non-essential genes, making it exquisitely adapted like a lean fighting machine for survival and causing disease only within its equine host. And this intense specialization is actually a significant factor in why it remains such a persistent global issue. It's really good at what it does in horses.
So how does this incredibly adapted pathogen actually spread and, take hold in a horse? What's the process?
Well, once Escherichia is either inhaled or ingested, it quickly sticks to the horse's buccal and nasal mucosa, the lining of the mouth and nose. From there, it moves incredibly fast, like within just a few hours, to the regional lymph nodes.
The ones under the jaw and throat, you mentioned?
Exactly, the submandibular and retropharyngeal nodes. This rapid invasion leads to that characteristic swelling and the abscess formation. You'll typically see a fever develop maybe 3 to 14 days after the horse is exposed.
And how infectious is it? Like, if one horse gets it, is the whole barn pretty much guaranteed to be at risk?
It's highly, highly infectious. Morbidity, the rate of sickness, can actually hit 100% in a population that hasn't been exposed before.
That's 100%. Wow.
Yeah, it spreads like wildfire in naive groups. Though thankfully, the mortality rate, the death rate, is generally low, usually less than 2% in uncomplicated cases.
Okay, that's somewhat reassuring.
Transmission is primarily direct, horse-to-horse contact.
Yeah.
And that includes horses shedding the bacteria before they even look sick.
Uh-huh.
But here's a really crucial part. Indirect transmission is extremely significant. We're talking contaminated objects, fomites, as we call them, like tack, grooming brushes, shared feed buckets, water troughs.
Even in people's hands or clothes.
Absolutely. Handlers moving between horses are a major route. And yes, even insects can potentially act as mechanical vectors, just physically moving the bacteria around.
And once it's out there in the stable environment, how long does equi actually survive? Because that must really impact how you try to manage an outbreak, right?
Exactly. That's a key question. Typically, equi survives in the environment for about 2 to 4 days. But, and this is a big but, under ideal conditions, think wet, cold environments, maybe where it's protected, inside dried mucus secretions, it can persist for up to 4 weeks.
4 weeks.
Yeah. However, it is quite susceptible to drying out, extreme heat, and direct sunlight. So in harsh, dry, or sunny conditions, its survival is usually limited to less than 3 days. Still, that window is enough to cause problems.
So it's really not just about isolating the sick horse then, it's the whole environment, the stable, the gear, everything. That sounds like a massive challenge.
It is. That environmental persistence is precisely why just isolating the clinically ill horses isn't enough. It's a start but. You need comprehensive biosecurity. That means rigorous cleaning and disinfection of all the equipment, the premises, everything. Plus, strict hygiene protocols for personnel moving around. This is exactly why outbreaks are often so difficult to truly stamp out and why the disease can become endemic, sort of always simmering in an area. It's a real uphill battle.
Given that it spreads so easily, how quickly do we usually see signs after a horse is exposed? What should owners be looking for first?
Right, so the incubation period, as we touched on, is typically 3 to 14 days, and the critical first sign is often fever, a temperature spike. This can actually appear 24 to 48 hours before any other symptoms show up.
Ah, okay, so temp checking is vital.
Absolutely vital. Temperatures can range from 103 up to 106 Fahrenheit, so 39.5 to 41 Celsius roughly. It's a significant fever.
And when do they actually start being infectious to other horses? Is it right away?
They typically begin shedding the bacteria becoming infectious about 1 to 2 days after that fever starts. And they can keep shedding for at least 2 to 3 weeks, sometimes longer.
Wow, okay. So there's only a day or two warning with the fever before they're spreading it.
Exactly. That very short interval between fever onset and shedding makes early detection based on temperature absolutely paramount for outbreak control. It really underscores the critical need for routine, ideally twice daily, temperature monitoring of all horses, especially any new arrivals or horses that might have been exposed somewhere. Prompt isolation and testing based on that fever can significantly alter an outbreak's trajectory. It buys you crucial time.
So the fever's there. What happens next? How does the disease typically progress after that initial temperature spike?
Well, within about 24 to 48 hours of the fever starting, you'll usually see the horse become depressed, lose its appetite, go off its feed, and then that nasal discharge starts. It usually begins watery, but quickly becomes thick and pus-like, typically white or yellow. Mucopurulent is the term.
Right.
The hallmark sign, of course, is that lymph nodes swelling, the submandibular ones under the jaw, the retropharyngeal ones in the throat. These swell up, form abscesses, and then eventually they mature and rupture, draining pus.
That sounds pretty unpleasant.
It is. Other signs can include difficulty swallowing, dysphagia, maybe that abnormal respiratory noise like wheezing, a persistent cough. And you can often see that characteristic posture, the horse holding its head and neck extended, trying to relieve pressure and pain. In really severe cases, if the swelling compromises breathing significantly, an emergency tracheostomy might even be needed just to help the horse breathe.
It sounds like a pretty clear-cut picture in most cases, but are there ever instances where it doesn't quite fit that classic description? Atypical cases?
Oh, absolutely. You definitely see atypical presentations. It's not always textbook. For instance, older horses, or maybe ones that have been exposed before or vaccinated, they might show milder signs, what we call atypical strangles. This could just look like nonspecific flu-like symptoms, maybe a transient fever for only a day or two, some nasal discharge, maybe off their feet a bit.
So easy to miss or mistake for something else?
Very easy. About half of these might just have moderate swelling of the lymph nodes under the jaw, not the huge dramatic abscesses. Conversely, young horses, especially those between 1 and 5 years old, seem to get it most severely, and foals as young as 3 months, as well as very old horses, tend to exhibit more severe signs.
Okay.
So this wide spectrum of how it presents creates a real diagnostic challenge. It allows those milder cases to be overlooked sometimes, and that leads to silent spread within a population, which is why definitive diagnostic testing, actually confirming S. equi, is crucial, even if the signs seem mild or a bit off.
But then there's an even bigger challenge to controlling strangles, isn't there? Something that makes this disease so incredibly persistent. You mentioned the silent spreader, the carrier state.
Ah, yes, the carrier state. This is arguably the true villain in the whole strangle story.
Yeah.
Not the obviously sick horse, but the healthy-looking carrier. A significant chunk, maybe 10% or more,
Yeah.
of horses that recover from strangles become persistently infected. They harbor S. equia, usually hiding out in their guttural pouches, those unique air sacs in the horse's head near the throat.
So they look fine, but they're still carrying the bacteria.
Exactly. These healthy-appearing animals are absolutely vital for outbreak recurrence and for spreading the disease far and wide, even across international borders.
Yeah.
The bacteria actually undergo genetic changes, like altering their surface proteins to help them evade the horse's immune system and just linger.
How long?
Well, recovered horses can shed intermittently for at least 6 weeks after they seem better, but some, they can shed for months or, incredibly, even years.
Years. Wow.
Yeah. And this is so critical because the asymptomatic carrier state is the single biggest obstacle to controlling and eradicating strangles. These hidden reservoirs just keep the cycle going. They made traditional control methods, which often focus only on the clinically sick animals, largely ineffective for really getting rid of it long term. I remember this one outbreak. We thought we had it contained, everything seemed clear. But then cases kept popping up sporadically.
Frustrating.
Incredibly. It was only when we went in with an endoscope and looked inside the guttural pouches of a horse that had recovered months earlier. There it was, pockets of infection, silently shedding. A real aha moment about how tricky this is. And the lack of routine pre-import screening specifically for these carriers, that's a massive global biosecurity vulnerability.
Okay, so if a horse is showing signs, you might make a presumptive diagnosis based on that classic combo. High fever, the abscesses, seeing it spread quickly. But for definitive action, like quarantine or treatment decisions, you need precise diagnostics. Looking at the options culture, PCR, serology, it seems like each has its own set of pros and cons. It's not just run one test and you're done, is it? How do vets navigate that?
You're absolutely right. It's rarely that simple. We have several definitive diagnostic tools, and each gives us slightly different information with its own strengths and weaknesses. So first, there's bacterial culture. This involves taking a sample maybe from a nasal swab or pus from an abscess or a wash from the throat area and trying to grow live S. equi in the lab. Historically, this was kind of the gold standard. If you grow it, you know it's there and it's alive.
That sounds like there's a but.
Yeah, the buts it can take 2 to 3 days, sometimes longer, to get results, and you can get false negatives. Maybe the sample wasn't great, maybe transport damaged the bacteria, maybe there just weren't many live bacteria in that particular sample, especially if there's lots of pus. And standard culture usually can't tell a vaccine strain from a wild field strain without extra specialized testing.
Yeah, so culture is one option. What else? You mentioned PCR.
Right, PCR testing, polymerase chain reaction. This looks for the bacteria's DNA, specifically targeting a sequence unique to S. equi, usually from the M protein gene, SNM. The big advantages here are enhanced sensitivity. It's much better picking up small amounts of DNA, so fewer false negatives.
Good for carriers, then.
Excellent for detecting carriers, yes. And it's usually much faster. Results can potentially be back the same day or next day. The main limitation, though, is that PCR detects DNA, but it can't tell you if that DNA came from live bacteria, dead bacteria, or even from a recent modified live vaccine.
Ah, okay. So a positive PCR doesn't automatically mean active shedding infection.
Not necessarily on its own. And it can stay positive for maybe up to 30 days after using certain vaccines. Also, sometimes you get results reported as suspect. Labs have different criteria, but generally those need caution. You usually treat them as potentially positive until proven otherwise.
And the third one was serology, blood tests.
Yep, serology. These tests look for antibodies against S. equin in the horse's blood. This doesn't tell you if the horse is currently infected or shedding right now. Instead, it tells you about the horse's immune response. So it's useful for things like screening horses before they travel or go to competitions to see if they've been exposed recently. It can help diagnose an acute infection if you see antibody levels rising between 2 samples taken a couple of weeks apart. It can indicate past infection or recovery. Antibodies usually stick around for up to 6 months.
So good for checking immunity.
Yeah, assessing immunity levels, maybe figuring out herd exposure levels on a farm, or even guiding decisions about when or if to vaccinate.
So, putting all this together, then, it really sounds like there isn't one single perfect test that works for every single situation. What does that mean for vets trying to diagnose?
It means exactly that. A multimodal approach, using different tests strategically, is often the most comprehensive way to go.
Yeah.
For instance, PCR is generally superior for rapid screening, especially for finding those carriers. Culture is still valuable for confirming active infection, especially from draining abscesses, and it gives you live bacteria if you need to check for antibiotic sensitivity, though that's less common now.
Right.
And serology gives you that bigger picture view of exposure history and immunity, both for individual horses and the whole herd. So the choice of test really has to be strategic. It needs to be tailored to the specific clinical situation or the epidemiological question you're trying to answer at that moment.
And regardless of which test you choose, getting a good sample must be absolutely critical for getting an accurate result. What kind of samples usually yield the best results?
Absolutely crucial. Sample quality is everything. For acute or subacute cases, horses showing signs in nasopharyngeal wash is often best. That involves flushing sterile saline deep into the nasal passages and collecting the fluid. It samples a large area, increasing the chance of picking up the bacteria.
Okay.
Nasal swabs are also commonly used. Usually you'd take two simultaneously, rub them inside the nostril for about 20 seconds. One goes for culture, one for PCR. And of course, if you have an abscess that's draining pus, collecting that exudate directly is a great sample.
And for checking carrier status?
For confirming or ruling out carrier status, guttural pouch washes collected via endoscopy are the most sensitive and definitive method. You're sampling right where the bacteria tend to hide.
Right. Makes sense.
And to be really sure a horse isn't a carrier, the recommendation is often 3 consecutive negative guttural pouch washes, collected maybe 7 days apart over a 21-day period. Proper handling is key too. PCR samples need to be chilled and sent for overnight delivery. Culture samples ideally need special bacterial transport media, like anis, kept chilled, especially if transit takes more than 24 hours. Your vet knows the drill. Getting those samples right and quickly to the lab is half the battle.
Okay, with diagnosis unpacked, let's pivot to managing strangles. If a horse is diagnosed, what are the main goals of treatment? And what kind of immediate care do we typically provide?
Right, so the primary aims are threefold, really. 1, control the transmission, stop it spreading further. 2, eliminate the infection in the individual horse. And 3, ideally help the horse develop future immunity. Supportive care is absolutely key. That means basic, good nursing. A warm, dry, dust-free environment. Make sure they have palatable food and fresh water, easily accessible, as swallowing might be sore.
Anything specific for the abscesses?
Yeah, applying warm compresses can help encourage those abscesses to mature and eventually drain. Once they rupture or are lanced, flushing the cavity gently with a dilute antiseptic solution like povidone iodine is important. Judicious use of NSAID's non-steroidal anti-inflammatory drugs like phenylbutazone or flunixin is also really beneficial for managing the pain and high fever. And for those severe cases we mentioned, especially if they're struggling to breathe or swallow, more intensive care might be needed. That could involve a tracheostomy, intravenous fluids for hydration, or even feeding through a nasogastric tube.
Now, antibiotics are usually our first thought for bacterial infections. So why is there such a strong debate, almost a controversy, around using them for strangles? It seems counterintuitive.
It does seem counterintuitive, doesn't it?
Yeah.
But it's a really important point of discussion with strangles. Here's the deal. Giving antimicrobials like penicillin very early in the disease, say, within 24 hours of the fever first spiking, might actually prevent the abscesses from forming and stop the horse from shedding bacteria.
That sounds good.
It sounds good, but there's a significant downside. Doing that can also prevent the horse from developing a robust protective immune response to S. equi, which means they remain susceptible to getting infected again relatively soon. You basically short-circuit the natural immunity process.
Ah, okay, so for typical cases.
So for uncomplicated cases, once those lymph node abscesses have clearly formed, antibiotics are generally not recommended. Using them at that stage can actually prolong the time it takes for the abscesses to mature and drain, and it still interferes with developing good, long-lasting immunity.
So when are antibiotics indicated then?
They are indicated and definitely necessary for horses showing severe signs. Things like marked difficulty breathing or swallowing, a prolonged, very high fever that isn't coming down, severe lethargy or complete refusal to eat or drink. And they're essential if complications develop, like metastatic strangles spreading internally or that immune issue, purpura hemorrhagica.
And if they are used,
Procaine penicillin is generally the antibiotic of choice, as S. equi is usually very sensitive to it. Also, just quickly circling back to the guttural pouches, if those infections aren't treated properly and become chronic, leading to persistent pus, empyema, or those dried pus balls, chondroids, that often requires intensive treatment. Copious lavage, maybe using agents to break down the pus, endoscopic removal of chondroids, and sometimes local antibiotics instilled directly into the pouches.
okay, so treatment can be complex, sometimes involving not using antibiotics. That really highlights prevention. What about stopping this pervasive disease in the first place? What are the absolute biosecurity essentials?
Prevention is absolutely key, and biosecurity is the cornerstone. First off, remember, strangles is often a reportable disease, meaning vets and owners may have a legal obligation to notify animal health authorities. This helps track and control spread. Key preventative measures start with new arrivals. Isolate all new horses for a minimum of 14, ideally 21 days, and monitor their temperature twice daily during that period.
And if there is an outbreak?
Then you need to quarantine the entire premises. That means no horses in or out, usually for several weeks after the last case resolves. And within the premises, you need to physically separate horses into distinct groups. Definitely affected horses, potentially exposed horses, and clean, unexposed horses, ideally in different barns or well-separated paddocks.
With separate everything.
Absolutely.
Yeah.
Implement strict biosecurity protocols. That means assigning separate caretakers and equipment feed buckets, water troughs, grooming tools, tack for each group. Or ensuring meticulous disinfection between groups if staff must move between them. Use protective clothing, like coveralls and boots, that are specific to each group, or disinfected thoroughly when moving, and maintain that twice-daily temperature monitoring for all horses on the property.
What about cleaning?
Thorough cleaning and disinfection of anything potentially contaminated is vital. Use a detergent first to remove organic debris, then apply an appropriate disinfectant. Things like chlorhexidine gluconate or glutaraldehyde-based products are often effective against S. equi. And remember, allowing surfaces to dry fully, exposure to air and sunlight helps too. And don't forget things like fly control and ensuring strict hygiene for anyone coming onto the farm, farriers, trainers, vets. They can inadvertently carry it on equipment or clothing.
It sounds like a lot of work. What about vaccines? Are they a silver bullet for prevention? Seems like there'd be huge interest in that.
Vaccines are definitely part of the toolkit, but unfortunately not quite a silver bullet. There are two main types available for healthy horses: an extract vaccine given intramuscularly, IM, and an attenuated live vaccine given intranasally, EAM. The IM products have been shown to reduce the clinical attack rate, the percentage of horses getting sick if exposed, by about 50%. So helpful, but not complete protection.
And you wouldn't use them during an outbreak?
Generally, no. Vaccination is not recommended during an active outbreak or for horses that have definitely had direct contact with a sick horse. It doesn't help much then and can potentially confuse diagnostic testing. The intranasal vaccine, which uses a modified live bacterium to stimulate immunity right at the nasal passages, has had some reported complications. Things like occasionally causing mild vaccine-associated clinical signs itself, sometimes abscesses if it accidentally contaminates a later injection site, swollen lymph nodes, nasal discharge, and in very rare instances, it's been linked to purpura hemorrhagica.
So it's a risk-benefit calculation.
Exactly. The American Association of Equine Practitioners, AAEP, considers Strangles vaccines risk-based. That means the decision to use them should be made in consultation with your veterinarian based on the individual horse's risk of exposure, the prevalence of strangles in your area, and the specific management situation. They are a tool, but not a magic wand, and need careful consideration.
What about those horses that appear to have recovered and that ongoing challenge of carriers we talked about earlier? How do we manage them post-illness?
Right, this is crucial for breaking the cycle. Remember, horses recovering from clinical strangles can continue shedding S. equi for about 4 to 6 weeks on average after the signs resolve. So screening them to check if they're still shedding or have become a carrier should only start after they've been clinically normal for at least 3 weeks. No point testing sooner, they're likely still positive.
And how do you screen them effectively?
The most sensitive method for really confirming if a horse is clear or is a carrier is testing a bilateral guttural pouch wash sample, one collected from both pouches via endoscopy using PCR.
Okay.
Alternatively, for releasing horses from quarantine, sometimes 3 consecutive negative nasopharyngeal washes, taken at 7-day intervals, might be used. It's less sensitive than the pouch wash, but more practical in some settings. It's also important to note that prolonged shedding, sometimes lasting up to 18 months or even longer, can occur if a horse develops that chronic guttural pouch empyema or has chondroids.
So they need treatment for that first.
Yes, those cases require specific treatment for the pouch issue, and then retesting afterwards to confirm they've cleared the infection. Honestly, the identification and appropriate treatment of these persistently infected carrier horses, that's considered absolutely paramount for effective disease management, not just on one farm, but at national and even international levels. They are the key to truly getting this disease under control long term.
Now, while you said strangles is rarely fatal, and most horses recover fully in maybe 3 to 4 weeks with few issues, this disease can have a much more serious, even scary side. Here's where it gets quite concerning, and definitely something every horse owner needs to be aware of, even if it's rare.
Absolutely. While the typical outcome is good, the potential complications, when they happen, can be severe and truly devastating. Owners need to know about these possibilities. One is metastatic strangles. It's sometimes grimly called bastard strangles. This is where the infection spreads beyond the head and neck lymph nodes and causes abscesses elsewhere in the body, most commonly in the lymph nodes within the abdomen, but sometimes the thorax or even rarely the brain.
Brain abscesses.
Yeah, though it's rare, S. equi is actually the most common bacterial cause identified in equine brain abscess cases.
Wow. Okay, what else?
Another serious one is purpura hemorrhagica. This is a nasty immune-mediated complication. It typically shows up maybe 4 or 5 weeks after the initial infection, or sometimes even after vaccination in susceptible horses. Basically, the immune system goes into overdrive, and antibody complexes damage blood vessel walls throughout the body.
What does that look like?
It leads to widespread leakage from blood vessels, causing hemorrhage and edema or swelling. Clinically, you see dramatic swelling of the limbs, chest, and abdomen. You see red spots petechiae, which are tiny pinpoint hemorrhages, or larger bruise-like patches called ecchymoses on the mucous membranes, like the gums. The horse will likely have a fever, be depressed, stiff, and sometimes fluid oozes through the skin, which can even lead to areas of skin dying off in severe cases. It's a veterinary emergency.
That sounds terrifying.
It is. Then there's guttural pouch empyema that we mentioned. If those initial infections in the pouches aren't cleared, you get persistent pus accumulation, empyema, or those hard, dried pus ball chondroids forming. This directly leads to that persistent carrier state, shedding bacteria potentially for years. We can also see S. equi-associated myositis, which is another immunological complication, this time affecting the muscles, causing severe muscle pain and damage. And finally, as we touched on before, just the sheer size of those swollen retropharyngeal lymph nodes at the back of the throat can cause severe respiratory distress and difficulty swallowing, sometimes bad enough to need that emergency tracheostomy just to secure the horse's airway. So yes, while strangles often resolves well, it's crucial for owners and vets to understand that rare doesn't mean never. These complications can be truly devastating. It's absolutely not a disease to take lightly, despite the generally low mortality rate for uncomplicated cases.
What an incredible deep dive into equine strangles. It's really something. A disease that's been known for centuries, yet its stubborn persistence seems driven by such complex factors. You've got the bacterium's amazing evolutionary adaptation, its laser focus on horses, and then surprisingly, the huge role of human activities, both historically and even now, in its global spread. There's a dark irony in that, isn't there?
There really is, and if we connect all these threads, all these pieces we've discussed, it just hammers home the critical importance of several things. Early detection, primarily through just simple routine temperature monitoring. That's huge.
Yeah.
Then the challenging but absolutely vital role of identifying and managing those asymptomatic carriers of the silent spreaders, and the need for that smart, multimodal diagnostic approach combined with really stringent biosecurity protocols. Knowledge in this case truly is power when it comes to managing this incredibly pervasive and persistent pathogen.
Well, thank you for guiding us through that. That was fascinating. And thanks to all of you for joining us on this deep dive. We hope you're now feeling much better informed, perhaps with plenty of surprising facts to chew on about strangles.
Yeah, and maybe this raises an important question for you, the listener, to consider. Given what we know about S. equi's evolutionary resilience, its ability to adapt and hide, and given how human actions, our movements, our management practices have undeniably shaped its global prevalence for centuries, what innovative new strategies, thinking beyond just the traditional methods we've discussed, what new ideas do you think are needed to finally curb this centuries-old equine challenge in our increasingly interconnected world? Something to ponder.